Good morning, good afternoon, and good evening, everyone, wherever in the world you may be joining us from today. My name is Francesco Del Carpio, and I am the CFAL York Operations Coordinator. I would like to officially open the third session of the Emergency Management in Hospitals and Healthcare Speaker Series with a land acknowledgement. We acknowledge and recognize that many Indigenous nations have long-standing relationships with the territory upon which our campuses are located that precede the establishment of York University. The area is known as Tekaronto and has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation, and that the territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As this is an online event and our participants may be joining from various locations, I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our speaker, and our participants from around the world. Welcome to our webinar. Without further ado, it is my great pleasure to introduce our moderator, Misha Richard. Misha Richard is the current Emergency Preparedness Lead for the Thunder Bay Regional Health Sciences Centre in Thunder Bay, Ontario, Canada. In this role, she acts as a subject matter expert, assisting with the development and maintenance of emergency management governance, training materials, and exercises. Misha also volunteers as an editor for the Canadian Journal of Emergency Management and is happy to be a collaborator and facilitator for this CFAL York series. She holds a Master of Disaster and Emergency Management degree from York University and bachelor's degrees from Western University and Brandon University in the focus areas of political science and disaster studies. Misha, thank you very much for moderating today's session, and the floor is yours.
Good morning, everybody, and thank you for that introduction. First, I have the delight of explaining some of our housekeeping before I introduce our fantastic speaker for today. So it shouldn't be a surprise, given this is our third session, on a little bit of our structure. So our participants are muted, but you are encouraged to have your own chat and dialogue in our webinar chat. If you have actual questions, we do want you to focus those and put them into our Q&A so that I can properly moderate those questions as they come through. And in conversation with our speaker for today, we do have a couple of points within the presentation where we can stop and take some questions as well as at the conclusion. However, if there's a really interesting one that pops up and I think we should address it before we move on too far, I do have permission to give a little bit of a poke to our speaker, and we can see if we can answer that question in real time. But again, please feel free to communicate amongst yourselves and keep the conversation going in the chat throughout and direct those actual questions into our Q&A so that I can properly moderate. So with that, getting through our housekeeping, I can introduce our speaker today, Mike Dickie. So Mike's an experienced emergency management professional who's been working for Nova Scotia Health since 2019. His education includes graduating from the Nova Scotia Community College with an advanced diploma in emergency management honors and class leadership award. And in 2019, completing the business continuity education program through DRII with an associate business continuity practitioner designation in 2021. That's always a little bit of a mouthful. He's also currently continuing his education through the Justice Institute of British Columbia and Bachelor of Security and Emergency Management. Mike is an active member of the International Association of Emergency Managers Canada and is currently working towards the AEM designation. He started with Nova Scotia Health back in 2019, as I mentioned, but in an advisor supporting the Western Zone. And in 2021, he was promoted to the position of Manager of Emergency Preparedness Acting and continues in this position today. Mike's experience includes responding to a multitude of incidents, and he most recently had a leading role in the response to the Shelburne-Barrington fires, impacting the local communities and requiring the total evacuation of a local hospital while maintaining healthcare options locally, which is at this point in time a good point to turn it over to Mike to talk about just that. Thank you very much, Mike.
Thank you, Misha. Just struggling to find the unmute there. Just confirm, can you see my screen fine there? Yeah, perfect. All right. Thank you, everyone. As Misha said, I am Mike Dickie. I'm the acting manager of emergency preparedness for Western Zone of Nova Scotia Health. And I am here today to speak to you about the impacts of the 2023 wildfires in Southwest Nova Scotia and how we ensured the continuity of healthcare delivery throughout the 10-day period. So a brief overview of Nova Scotia Health for those of you that don't know. Nova Scotia Health employs around 25,000 staff in addition to the physicians across the province. We serve over 1 million Nova Scotians and others from our neighboring provinces. We have 42 hospitals and over 100 community-based locations spread across the province. We are broken up into 4 operational zones. So the Western Zone, Northern Zone, and Eastern Zone, the blue, green, and light purple there are a mix of small urban towns and rural healthcare areas. And then the Central Zone, the gray in the middle, is mostly made up of the Halifax Regional Municipality, or the city of Greater Halifax, which houses the tertiary hospital in the province. And then a number of hospitals outside of the city are also located in quite rural areas throughout the province. Speaking specific to the Western Zone for geographical awareness, these hospitals that fall under my team are from Wolfville over to Bridgewater and then down to Yarmouth, if you know where any of those locations are. So the Nova Scotia Health Emergency Preparedness Team conducts hundreds of education, training, and exercises for the organization annually, and we respond to and support a number of incidents and events throughout the years. These include obviously wildfires, recent flooding incidents, preparing for hurricanes as we watch our forecast for the coming weeks. We know that is likely to be something that we deal with. So that's what our team does. And we work closely with our partners such as Nova Scotia Emergency Management Office, EHS, which is the provincial ambulance service and policing agencies. Although we work closely with Nova Scotia EMO, we're not actually part of their organization. We are a standalone team working directly for Nova Scotia Health. There are 16 positions within our team. Our director obviously has an overview of the whole provincial program. Then we have 5 managers with 1 positioned in each zone and a manager of projects and planning, 5 advisors covering the same landscape, 3 administrative assistants for the whole program, and then 2 positions that work with us and the Nova Scotia Trauma Program to develop the mass casualty plans for the organization. Speaking specifically to the southwestern fires in Shelburne County, just an overview of Shelburne. It has a population of, the Shelburne County has a population under 14,000 and is largely driven by fishing and forestry in the area. Keep in mind through this presentation that at the same time as the fire was burning in the south end or the southwest area of the province, there was also major fires burning in Central Zone, so just outside of the downtown core of Halifax. These fires in Halifax were smaller in nature, but in a much more heavily populated area, posing their own challenges. So you can imagine that both provincial and municipal resources quickly became very taxed and constrained. So the flow of information at times was challenging due to the nature of multiple incidents coming on and occurring at the same time. Both of the major fires started on the same day around the same time. All of these fires resulted in the declaration of multiple states of local emergency across the province and requests for assistance from other jurisdictions. Before we jump in, is there any questions about Nova Scotia Health?
So I don't see anything in the chat as of yet. So I think that was a good overview. Thank you very much, Mike.
Excellent. Thanks, Misha. Okay, so looking at the Barrington Lake wildfire, to paint you a picture of the climate we were experiencing, the winter precipitation in Nova Scotia last winter was around average, maybe a little bit below, but the temperatures were high. So it led to less snowpack and ice in the rivers and lakes. So we had minimal spring melt. So starting off our spring, we were drier and warmer than average. Between December and Nova Scotia, we were down anywhere from 10 to 40% normal precipitation levels. And April received approximately 20% of the expected rainfall. So that translated in southwest Nova Scotia to being down by more than 75 millimeters in April alone. So the Barrington Lake wildfire is now the largest recorded in Nova Scotia history, with over 23,000 hectares burnt, 60 homes lost, and 5,500 residents displaced. So 5,500 residents translates to about 40% of residents of Shelburne County were actually displaced from their homes during this fire. Just for a little situational awareness and how we gathered this, the Barrington Lake wildfire was located between Yarmouth and Shelburne. You can see on the map here the fire on the bottom, and then the directional arrow showing where the highway leads to the 2 nearest hospitals. Those hospitals are approximately 100 kilometers separated by a 2-lane highway, obviously closer as in a straight line. Our first notification came via social media on the Sunday around noon. Myself, as the emergency preparedness manager, connected with the site lead and the manager on call for the operational zone. Site lead actually went into the hospital to support the staff in the initial hours and really give us that local knowledge of what was actually happening. But we quickly realized we needed more information. So I did connect with our community partners. Reached out to the Nova Scotia Emergency Management Office duty officer, who initially, the report from them was that local road closures and evacuations were being reported, and a small section of Highway 103 was closed because the fire had actually jumped. But it was localized impacts, no direct impacts to Nova Scotia Health. Our staff and patients could access via secondary roads. The air quality was fine, and there was no threat to our facility. So the decision was made for us to remain connected through the evening, but to continue to use our normal monitoring and after hours operations for connecting. The first impacts started to be felt really Monday morning. We established an incident management team for 9 o'clock to look at these impacts that were affecting us. So access to the facilities, obviously a larger section of the highway was closed. That on the screen there is about a 10-kilometer section that was closed where the fire had jumped in 2 different locations. And we had staffing on both sides. We started to get requests for community support coming into the comfort centers that had already been established for mental health supports, primary care, and others. So obviously, we as an organization needed to start looking at our evacuation planning. We did this by obviously reviewing our plans and our memorandums of understanding and planning for the potential evacuation of the 23 inpatients at Roseway Hospital located in Shelburne. The biggest issue we were dealing with initially was actually network outages. The internet service provider had sustained pretty serious damages in the initial hours of the fire, and we had limited to no network connectivity from the Shelburne area all the way up to Lunenburg. So 4 hospitals in between were with very limited network connectivity. It was at this point that we started realizing the likely impacts on the healthcare system and really established our regular incident management team meeting and cadence from there. Our first meeting, I will admit, was pretty rough. We didn't have internet, so we had to use a conference call, and the networks were really busy. It was very hard for us to manage that. So we were grateful that the internet came back on around noon that day and got into a bit better of a cadence. We know during incidents like this, the clinical planning to alleviate pressure points is our best option. So we worked with our director of access and flow, who actually started in her role that morning, to work with her team to see how we could relieve pressure. First thing we did was close the admissions pathway through the emergency department into the Roseway Hospital, just to alleviate, as we sent patients home, we didn't want to be adding more that we would potentially need to evacuate. The patient flow team, along with the continuing care team and the long-term care sector, worked to expedite placements throughout the zone and the province for inpatients. I do want to acknowledge that our continuing care team is an internal team that liaises with the long-term care sector in Nova Scotia. However, the long-term care sector is under a different government portfolio, and these are mostly private entities that are across the province. So we don't actually work with them on, because they were impacted by needing to evacuate facilities. We don't work with them as Nova Scotia Health. The continuing care team integrates with them. And then identification and transfer of patients posing the greatest challenge in a potential evacuation situation. So this was looking at patients that may have had multiple comorbidities, difficult care plans, bariatric patients, someone who would be easily confused in a stressful situation. We identified which patients kind of met that threshold and found places for them outside of the hospital. Some went within the zone, and there was actually a few that went as far as Truro, just to get them out of our facility, so that if we did have to evacuate, we didn't have to deal with the increased challenge with those patients. So looking at our possible evacuation locations, we really went across the board to find the best suit for us. Starting on the map here on the left side, Yarmouth Regional, it is a large regional facility. with room for expansion into non-traditional spaces. However, it's on the wrong side of the fires. We would have had to circumvent the fires in a long direction, and it just didn't make sense to take the patients that far. Shelburne, Nova Scotia Community College, that's the place that we have an MOU in place for the Roseway Hospital, but it's across the street. So evacuating across the street in the evacuation zone obviously wouldn't have made any sense for us. Queen's General Hospital is another Nova Scotia health facility, not too far down the road. Little to no space for expansion, and it was pretty quickly taken off of the options for us just because we didn't have any room to place the patients. Social Regional Hospital in Bridgewater, it's a Nova Scotia health facility. It is a regional facility, but it's pretty well busting at the seams on a good day. So space is very limited. We were able to identify space in the building that for appropriate for the highest acuity patients. So we found 5 beds or spaces for beds in there, working with the local team, and had those kind of earmarked for some of the higher acuity patients if we needed to. Nova Scotia Community College, as we do have agreements with them for most of our facilities where they're located, that one was actually made immediately available for us, and a team of us did go to the facility to look at it. They have a non-traditional clinical space that is available, though it does lack some of the essential aspects for patient care. And what I mean by non-traditional clinical space, we'll bring up a picture here. That's the area that they do their nursing program. So that's in the college itself. So great that we had the beds and some of the services, but we obviously don't have the monitoring, the network connectivity, access to medications. And even in this building, that part of the building is not on their emergency backup generator. And there would have been a lot of pieces for us to get moving to use that. So it's still on the table. It's something we still consider as an option if we ever had to go from one of our buildings, but it wasn't the right fit for us in this moment for this evacuation. So we did end up landing on Fisherman's Memorial. It's a hospital in Lunenburg. We went into a space that is currently being developed for a palliative care unit. So this area didn't have beds, or didn't have enough beds in it, I should say. It is a Nova Scotia health facility, good and bad. It's the farthest from the fire. So good, they're out of the danger area. Bad, we had to move the patients the farthest to get them to where they were going. Considerations for all of these was obviously space, staffing, access to medications, and network. Probably the biggest barrier that we had to deal with for any of these was the equipment or the lack thereof. Nova Scotia Health does not have a cache of beds just sitting ready for use in the event that we had to evacuate a building. So we did identify 9 beds in the province, mostly within the zone or just in the central zone that were due to be decommissioned, but had not yet been done so. So those beds were actually brought in along with other equipment. So we had equipment arrive from 5 different locations via 6 different vehicles in a matter of 5 hours. We told them that we needed it and we were doing it, and within 5 hours they were all in the building ready to set up. So ramping up our response, you can see here in the picture that the fire had grown once again. A 14-kilometer stretch of the highway was closed at this point. In the end, this fire did end up closing about a 29-kilometer stretch of the highway. Ask for support in the community centers had grown even further. They were starting to establish recovery centers where they could do some notification to folks if they had lost their home or not. So more asked for support from our teams in there. Through the night of May 30th into 31st, there was a code gray or an external air exclusion was declared within the Roseway Hospital. So the maintenance team obviously turned down the air handling units. Masks were made available for staff and patients. It lasted about 60 to 90 minutes, and then we were able to call it off. But the indication from the local incident management team later that day on the 31st was that the conditions were right for the fire to be moving away from the hospital. There was no longer a real threat to the hospital that the fire would continue moving in that direction and have any threat of jumping the harbor or becoming too much of a concern for us. We had clear direction that we were not going to be evacuating unless the fire really threatened the facility. Mitigation plans were in place for smoke impacting the buildings. The same went for closing the emergency department. It was critical that we kept that open as long as we could. So the ED would be staying open as long as the inpatients were staying in the building. We did have an added complication throughout the day on the 31st, that there was a second fire that popped up south of the highway. This one was impacting more home care clients, more of our staff, threatened the highway 103 because it was on the other side of it. And ultimately, it pulled resources away from dealing with the biggest fire to go and contain that one before the two could combine and merge. So as the day on the 31st seemed like it was wrapping up and things were slowing down, our planning was complete, though we didn't believe we would need to move the patients given the current information we were being provided. I was providing a situational report to the leadership. I received a phone call from my advisor and texted him back right away and said, "Can I call you later?" And his response was, "Shelburne Fire responding to a woods fire not far from the hospital at 1149 Lake Road in Sandy Point." Now, Lake Road is the same road that the hospital is on. He followed that up with this picture here. So the building you see is Roseway Manor, which is a long-term care home that had already been evacuated, but you can see the smoke quickly billowing up behind. It was a nice clear blue day, so we knew that those weren't clouds coming up over the skyline towards us. So he sent us that, and we knew that it was time to go and put the planning into place. So the fire was initially located about 1.5 kilometers from the hospital. The final patient census was complete. We knew that we had 15 patients that we needed to move out. The number 15 is obviously in thanks to the work that was done earlier in the week by the patient flow team to move out those other 8 patients from the building. The confirmation of transportation plans was done with our 4 highest acuity patients prepared for EHS transfer, and the remaining 11 patients were being prepared for transfer via a local school bus. The bus did include 3 nurses and 1 nurse following in a car, and EHS and other emergency services were aware that these patients were moving and had units ready to respond if complications were to arise. We did have 1 patient who had just self-presented into the emergency department and was offered an EHS ride, but they decided to self-transfer themselves to Bridgewater as well. The receiving facilities were both prepared, staffed, and ready for the patients. As someone who was standing in Lunenburg, I can tell you there was at least 20 people standing outside that building half an hour before the bus would even get there, ready to receive the patients. The beds were made. Food was ready for them, everything to make them comfortable and help get them off of the bus. Notification to the families, obviously that is a huge piece in an emergency like this, letting them know the situation that's going on so they're not blindsided by that. Staff members were in contact with all 15 patients next of kin at the onset of the fire, when they were put onto the bus, and then when they were safely at their destination. The total evacuation time for the patients in the building took 2.5 hours, and within 2 hours after that, all patients were in bed 134 kilometers away. So our first notification of the fire did come at 4:32, and patients were all in bed shortly after 9 o'clock that evening. At this time, once the patients were evacuated, a code green stat was called for the facility. There was a bit of delay in getting the last couple folks out of the building. Given that this building does have its own boilers in it, the maintenance team identified that they can't just go. They need to shut off those systems, drain the pressure so that it doesn't become a hazard within the building itself. So that was a lesson learned for us that we've since incorporated into some of our plans, that if you have to leave the building, if at all possible, we need to engage with maintenance and other programs to say, what do you absolutely have to do to shut down before we leave? I cannot speak highly enough regarding the importance of having EHS, the ambulance service, working right with us. During incidents like this, we do embed EHS right in our incident management team throughout the incident. We did have a team member on site to help with the evacuation support and coordination. And through these efforts, they were able to quickly get those 4 trucks identified and redirected to the facility. You have to think that was probably one of the busiest times on record for EHS. For them to find us 4 trucks in a moment's notice and get them there to get those patients out, it couldn't have been done without that real ears on the support on the ground within the hospital, coordinating that. And then our partners at the municipality of Shelburne, we had transportation arranged. However, it was using our own equipment, and it was a distance away from the facility because we hadn't shifted it down there yet. The school bus was provided by the municipality of Shelburne and the School Center for Education in the area. So that really expedited from the point that the CAO walked in to tell us that we were going to be in the mandatory evacuation area. It was about 15 minutes until the school bus arrived and we were able to start putting patients on there. Just a couple pictures from Yarmouth. So this was on Friday. So the evacuation happened Wednesday night or Thursday night. And then these are from Friday, where this is in Yarmouth. So the winds had shifted and started blowing the smoke in a different direction. The center picture is the app called Purple Air. It's a community science project that's aimed at providing what they say is hyperlocal and real-time air quality readings. I'm not sure if everyone is familiar with that, but it's a pretty cool little tool that you can use and look at your air quality statement if there's a measurement tool in your area. You'll see the top number here, 559. That was the 10-minute average. Our newest reading at this time was 653. And the warning level above 300 states health warning of emergency conditions. Everyone is more likely to be affected within 24 hours of exposure. Having that picture was just a timely screenshot from a colleague of mine that happened to have that. So I'm pretty thankful for that one. So the air exclusion was called for the regional hospital. Given the added complexities of a larger hospital like that, we can't just completely shut the air off. So it was reduced to the absolute lowest numbers that we could use. Masks were already pre-positioned through the buildings for patients and staff to put on if they needed to. And then our lovely comms team, they had actually developed communication plans for our internal comms ahead of time and sent them out to us and said in the email, it actually said Friday night is not the time to be creating communications. So we actually had these comms sitting there ready for us, and all we had to do was say, yep, send them out. We just tailored it a little bit and then sent them out. So now's a good time for a pause there, Misha.
Perfect. Okay, because I was going to say there are a couple of questions that have popped up in the chat. And what I actually have, and it goes back fairly early on in the presentation, but there was a question that had come about requesting how you got that initial first notice. The clarification was, did that come through on social media, or were you alerted in a different way with that kind of initial kickoff?
So my personal first notice came actually via a friend who raised it to me on social media. It was sent to me, and then we engaged with Nova Scotia Emergency Management. The site lead there, obviously, she lives very close to the hospital, so she was already made aware of that. We just quickly, it was probably pretty well simultaneously happening, and we connected pretty quickly. So yeah, so I was notified in a roundabout way via social media.
Okay, so then I have a couple more questions in here before we let you get back to it.
Yep.
There was an interesting question that was kind of centered around seasonal hazard risk preparedness, as far as there being a forecast. Do you have something like that? If you did, was this year sort of in alignment with actual events? You know, did the current trend follow previous year's patterns? So just sort of around that kind of seasonal risk preparedness, since you had mentioned that a little bit, I think, before.
Yeah, so we do get access to the reports from Environment and Climate Change Canada that give the previous quarter's results, and then kind of forecasting what the weather in terms of precipitation may look like. We obviously know that June 1st is the start of hurricane season. So we all, as an emergency preparedness team, we always share those bulletins out, whether it is extreme winter weather, hurricanes. In the past, we haven't done a wildfire one, but I suspect that there's probably one brewing on a desk somewheres that we'll be sending out come next spring when wildfire season comes around again.
Great. So then the last question I have for you that's popped up in our Q&A, and again, still encouraging for everybody in attendance, continue to carry on the conversation in the chat, but please feel free to drop questions into the Q&A for us. So the last one that I have at the moment was, when determining which patients move in advance, is there a framework that you're working from, or were these principles developed along the way?
So I would say that those were developed along the way via the clinicians that make those decisions. I'm not a clinician in any way. I wouldn't have had really any input into that. They're the ones that know what the care plans are for these patients. But that it is a good question, and we can certainly take that offline, and I'd be happy to connect with whoever asked that question, and I can ask that question myself within my organization, how they did that.
No, it's a good, I saw it come up and it is a good question, but I was wondering if that was something that was at a little bit more of a local, facility specific sort of consideration, or how much oversight, Nova Scotia Health Authority has on that particular piece. So I think maybe that's where that framework question had come in. So I will also say, if anybody wants to get a hold of Mike, we're not broadcasting his information, but if you provide your information, we'll make sure that your questions and your contact is provided to Mike for follow-up after. So on that note, I don't have any other questions that are floating around in the Q&A, so it's back to you, Mike.
Awesome. So it would have been real easy to come today and just talk about evacuation for 30 to 40 minutes, but I did want to touch significantly on the healthcare delivery in the community and how we ensure the continuity of those services. Really, there was 4 aspects to this that I wanted to highlight. Emergency department continuity. Rural health in Nova Scotia is not immune to emergency department closures, as it is similar across many jurisdictions, or most jurisdictions likely. The way that staff picked up shifts in there to ensure that they remained open, and thinking of a small community like this, those are staff that live in that community, or they're travel nurses who are in that community, going above and beyond to do that. Physicians identified to and offered to support. We have physicians coming from Yarmouth, so they had to go around the fires to get to the hospital to work. We have physicians coming out of Halifax who obviously were leaving a fire situation up there, coming down to help work, just to ensure that the emergency department remained open. As I said, EHS were extremely busy. People were being told that the wait for an ambulance might be longer. So if you can self-present yourself to the emergency department, it was imperative that we kept that ED open until the building had to be closed. Even after the building was totally evacuated and we shut it down, those staff and physicians didn't go back to their home base necessarily. A number of them shifted up the province to Queen's General Hospital in Liverpool, so about a half hour away. That was our next nearest emergency department. Once this one closed, that one became our priority, to keep that building open 24 hours to support the access to emergency care for the community members. Continuing care supports. One that was probably overlooked initially from the incident management team, but it quickly became a huge piece to this. They coordinated the care for over 200 clients who were directly impacted by the fires. Multiple members of those home care clients were actually homebound and needed additional support and evacuations from their homes. Now, we didn't coordinate the evacuation part. Nova Scotia Health incident management team didn't coordinate that part, but the continuing care team worked with the local incident management team, EHS, ground search and rescue to coordinate that evacuation, or those evacuations, I should say, and have those patients moved. The long-term care sector was so stressed at that point that some of these clients needed to go into a home, and at least one of them had to go to a long-term care home in Antigonish County, which is about a 5-hour drive away. That's just an example of how busy the system was, and they were able to expedite that placement and have them put into a home in a matter of hours, a process that normally takes a matter of days to do. Continuing care were able to put staff in the comfort centers, and they actually identified a number of clients who were not yet on the long-term care radar, who really met the threshold for either home care or long-term care placement, and we're able to get them in the system and help them along their way. And then the placement of the evacuated patients. A number of the patients at Roseway Hospital were in there waiting for long-term care placement. And rather than moving them from Shelburne to Lunenburg and then back to Shelburne and then to a long-term care home, they were essentially intercepted in Lunenburg and then placed in the long-term care home in their regular catchment area, just to avoid the moves. Less stress on the client, number one, less stress on the system to have to move them again after we did it already twice. Challenges that they noted, the scope of community impact and the safety of the staff and the community kind of tie in together. They know where all their home care clients are located. And if we could have been able to provide them with a better overview of the threats in certain areas, the impact that was being felt, they would have been able to coordinate a bit quicker, doing their check-ins. They can kind of check them off if someone's been evacuated, doing wellness checks. Keeping that all in-house would have been much easier if we were able to provide them that better real-time information. Sharing the workload, they kept the workload pretty close to the team in that geographical area, and they've identified that they really should have shared that wider, at least in the zone, if not throughout the province. And then the role clarification in the comfort center. As I've said already, the continuing care team of Nova Scotia Health is not the long-term care sector. They're just kind of the go-between for the acute care system and the long-term care system. So there was some confusion early on that these folks would be able to help those home care clients that absolutely need to go right into a long-term care home right away, but they're the ones that liaise with the private entities. Next up was primary healthcare. They initially deployed their staff on May 29th to the community locations, or to various community locations. They established clinics at the comfort centers and did end up serving hundreds of community-based clients over the more than 10 days of deployment. Their primary role was to provide a navigation pathway for enhanced care where needed and help with the lower acuity level of care for the patients. In Shelburne, they deployed one physician, 2 nurse practitioners, 2 nurses, and a dietitian, and the numbers or the complement was similar in the other location in Barrington. They were able to support the community really through 2 means of care. Continuity of primary care services through the mobile clinics. So the physicians' offices that needed to close, they picked up where they couldn't work. Patients were redirected to the mobile clinic for their normal appointments. For appointments and patients that were over and above, they were actually able to establish additional mobile clinics for the community. So they roll into town and have just, normally it's a sign up, but these were just walk up clinics for anyone who needed additional care after being impacted by this. Challenges, role clarification again in the comfort center. A mobile clinic is not a substitute for a closed emergency department. So there was some clarification needed around that with the local incident management team and the comfort centers, but it was easily worked out. Just a couple hiccups initially. And then geographical isolation. Staff working in around these areas identified times when they felt isolated due to the amount of traveling that they had to do, going into maybe places they weren't familiar with, places that had been evacuated. So establishing a way that we can support them in the geographical isolation is on the topic for us to look at. Finally, and the last one that I want to raise was the mental health supports here. The staff were deployed through the communities May 29th and remained until late June. In those true deployments, they actually continue to this day to be in the communities, doing community wellness sessions, working with the members who were impacted by this, just to help them navigate through the system and give them whatever supports they need. For the main deployment, they did see hundreds of community members, and their primary role was that navigation piece. They worked in the recovery and comfort centers and the virtual supports. Initially, we deployed 4 staff, or the mental health team deployed 4 staff to support. It quickly grew to 12 more on a rotational basis because these centers were 24/7. They didn't have someone in there necessarily 24 hours a day, but they had someone available. There was a diverse complement of practitioners. There was master's prepared practitioners, social workers, school plus practitioners, and clinical therapists, amongst others, that were there and available to help. The challenge, and this is a recurring theme, is the clarification of the role to manage the expectations. They were not there to provide a clinical intervention. They're there to navigate that. There's a lot of supports available for those members of the community that were coming in, and they were there to identify what supports would work best for them and help them along the way. There was at one point, there was some confusion around if these practitioners were the ones that would go into the recovery center for the notification. And they were not. They were not there for that. There's crisis intervention teams that do that through the comfort centers and the recovery centers. They were there to help with that. A good piece out of this was this was very improved once the mental health team were actually able to connect directly with the provincial recovery team that was being led by the Nova Scotia Emergency Management Office to clarify that role for what they were there for. The next piece that I wanted to raise here that came from the mental health team was something that actually came out of the Mass Casualty Commission, recommendation C13, funding a program to address the unmet need for mental health, grief, and bereavement support. While this recommendation is actually specific to the 2020 mass casualty incident in Nova Scotia, the program has been established and will be expanded after year one from the northern zone and scaling out provincially over the next 4 years. This work will be applicable and available to any traumatic events in the communities across Nova Scotia. So much of the work from this recommendation and the program that's actually been developed and is rolling out got a real early dry run with the fires in Nova Scotia, and they've actually made some changes to the program based on what they did here, and they were very appreciative of the opportunity to do this, and they've already learned from that. And as an organization that is committed to learning and improving, I think it's a good tip of the hat to the organization and the team going forward. Recovery for the system. We did receive advance notification of the evacuation order being rescinded on Sunday, June 4th. Recovery planning for us really started on the night of the 31st, sitting in the Fisherman's Memorial Hospital. The incident management team identified right away, like, everyone was there and safe, but we need to talk about how do we get back into that building when it happens, because the building, the evacuation order can be rescinded, but we need to get in there and do bring the building back online, because the community is going to want it as soon as possible. So we did send teams there on Sunday the 4th to start their process. The environmental services, maintenance, and IPAC went on site, or infection prevention and control went on site. A broader team was there on the 5th. I went with the team of diagnostic imaging, food nutrition, lab services, pharmacy, to make sure that all of their systems were up and running and ready for the reopening of the primary healthcare clinic and the emergency department on the morning of June the 6th. By the evening of June 6th, all the patients that were coming back were actually repatriated into the facility. So keys to success from this whole incident that were identified, and there's more, but these are the big ones. So early engagement with the patient flow team. I truly believe the evacuation wouldn't have went near as well as it did if we didn't move those 8 patients out earlier. Direct engagement with the physicians, having the ability to ensure that that emergency department would remain open, and then the next one would remain open, and the doc-to-doc conversation during the evacuation happened to ensure the transfer of care to another hospital. We had physicians that were normally in Shelburne that went to Lunenburg to care for their patients in that building. Evacuation planning and training, it's obviously a big one for our team in the organization, and we do a lot of work on that. And the work that we've done, the training that we've done, I think it set us up for success during this incident. Specific to the evacuation response, establishing a sending and receiving team for each of the facilities. So the sending team in Shelburne, the receiving team in Lunenburg. Those 2 teams were able to make sure that every checkbox was checked, and those of us working in the core incident management team didn't have to worry about the specific details of that. We were able to stay at that higher level and have them report into us. That was absolutely key to that. And then finally, and probably the biggest one here, was the support services in the community, where we were actually able to continue providing healthcare to those 14,000 members from Shelburne County, those members in Yarmouth County, the members of the community who were north of the area. And then obviously our areas for improvement, the implementation of a safety plan or officer for the community team members. This was really specific to the continuing care, primary care, and mental health. They had people going into the community, and they were checking in with their directors and their managers throughout the day and at the end of the day. But as an incident management team, we never actually talked about this, about checking in on those people who were in the field. And it's something that we absolutely need to have within our incident management structure. Developing a closer working relationship with the local emergency management office. Most of the regional emergency management office we have great relationships with them. This was the one area in my zone that didn't actually have a formalized emergency management office under their jurisdiction. They had started the process a couple weeks before the fire started. So they had people there doing it. It was off the side of their desk, hard for us to develop a relationship with them, but it's well developed now. We're working towards that. And I truly believe if another fire happened there, or a hurricane that is forecast for next week, we'd be able to connect with them and understand how they can help us and how we can help them. And then lastly, broadening the scope of the MOUs. Obviously, having an MOU in place for all of our buildings is excellent. But I'm willing to bet that most of our buildings in Nova Scotia Health and a lot of other buildings, healthcare facilities, their MOU is probably with something that's across the street, as a university or a community center down the road. But what if the whole community is evacuating? We need to have that. Nova Scotia Health is lucky that we have those 42 hospitals and other buildings across the province that we can rely on. But what if we couldn't rely on them? What if one of them didn't work for us? So broadening the scope of the MOU as an organization. And that's it, Misha.
Okay, perfectly right on time. 1 minute to spare. So now we can kick off kind of our last round of questions. So I do want to say a couple had come into the Q&A and a couple of them have been dropped to the chat. So I'll start with one initially that actually there's a couple that are tied back to the comfort centers. So the first one was essentially just asking for more information around the comfort center. So what type of facility are we really talking about? And what are sort of the services that end up being offered? And maybe that will help answer a subsequent question that had popped up in the chat.
Yeah, so the comfort centers are the ones that are established by the local municipality and their emergency management office. They're not a 24-hour shelter. They're somewhere that people can go get the supports they need, charge a phone, have a cup of coffee, some light snacks and whatnot. It's somewhere for them to go, kind of as a stopgap between evacuating their home to landing in a hotel somewhere or a friend's house, or if they end up being in a shelter. So the comfort center is there. The comfort centers are they work very closely with and are supported by the Red Cross to establish those. So a lot of times they're in like a fire hall or a community hall or a school.
Yeah, so I think that does touch on a follow-up question then, where there was a comment a little bit perhaps around semantics, so a little bit of kind of geographical terminology for something that the comfort center sounds like perhaps that's the equivalent of just like an evacuation reception center. So does that sound kind of for your area? Yes. Okay, so hopefully that helps out a couple of folks that had asked some questions. And another one came through as well, and hopefully we're able to kind of tease this out. But so the question was, are there tiered agreements with community colleges, universities, utilizing students and staffing support from academic centers?
Using staffing and student support, you mean? Is that what you said?
Yeah, so I was wondering if the direction they were going with this is, so even at my own facility, we have a very close relationship with a nursing program that's very close by. So I'm not sure if this kind of ties to that, but that was something that perhaps I think they were looking at, was sort of those agreements with, as stated here, community colleges and universities, utilizing the students and staffing support from those facilities.
So I can say that the MOUs that we have in place are primarily facility. We do get access to their maintenance team, their security, but in terms of staffing them is our responsibility.
Okay, so we still have a few minutes here. I haven't seen other questions come through. I'm just doing another really quick scroll through the chat to see if any ended up in the chat versus the Q&A. Okay, oh, wait, one moment. We've got another one. I was going to say just as soon as I close the screen, another one pops up. So we do have one asking, so how did you assist doctors, nurses, when they were asked about the evacuation response related questions and concerns from their patients? So I know actually you had commented that your comms team was pretty on the ball and proactive as far as having internal messaging ready to go. But perhaps this is a little bit of that chain of communication as far as how you were supporting them in getting those communications out to patients.
Yeah, so fortunately, we were able to use the staff, so the nursing staff and those physicians to communicate a clear message through them to the family members, to the patients of what was going on, why we were evacuating. We made it very clear that we're not doing this unless we absolutely have to. So the communications through them went through the patient navigators that are within the organization, and we gave them their pre-written talking points. Kind of developed the comms team did develop Q&A or FAQs, I guess, for this.
Okay, so I think that answers that, and there's been another one that's popped in as well. I think also just on that point, it certainly highlights, as your comms team highlighted themselves, you want to have those messages developed in advance so that you're not scrambling the moment of to try and get those messages out. So clearly that worked well during this response. So I do have a question that's come up, and I'm chuckling because it's a colleague of yours. So I guess it's a little bit of a response. So if the question is, can we access college staff during responses? They were answering not normally, but they were able to access, you folks were able to access students during COVID to support the system. But the logistics of this does take a while. So perhaps that's kind of a little bit of a supplementary piece. I don't know if you have any further comment on that to what your colleague had responded.
No, that's accurate.
Okay. And then so just kind of a general question that had come up asking if there were any specific challenges related to recovery processes that you'd like to expand on.
No, the recovery, we expected that the recovery would take probably 48 hours longer than it did. Everything in that situation just fell into place for us. We have no real good explanation of why it happened that way. I think we were due some good luck. So unfortunately, I don't have a real good answer to that one because it just everything went so well. I guess that probably is partially because we started the planning for that so early on. Like we had started recovery planning 4 days before we actually went back in, immediately after we finished the evacuation.
Excellent. So I don't have any further questions. We're a couple of minutes to the hour. I would pose just one quick question to say, what are sort of the next steps as far as you had commented, hurricane season and so on, that you guys already have had a very busy and active year under your belt, and the first full hospital, evacuation that you've had in many years. Yep. So what is the anticipation as far as ramping up for next seasonal challenges?
Obviously we are taking our lessons learned from this one. We need to do that, and identifying where we can improve. So that process is being done. One of my colleagues is leading the lessons learned process. That was a big discovery for us. Oftentimes we would do it ourselves, but because I was so embedded in leading the incident management team, it would have been too many faults in it if I was the one that led the lessons learned. So we had one of the other managers do it. So we're going through that, and a lot of it is going to be around that evacuation piece. I said from the get-go that we went, things went really well in the evacuation, but they could have went another way. Those beds that weren't actually in service could have been thrown out the day before. There's a lot of little pieces to that. So we are certainly focusing on that, identifying how we would activate our incident management team on a local and then a provincial level as well. The floods that occurred here recently, those were we dodged a bullet with those ones as a health system. The province was really hammered with them, but as a health system, we definitely dodged a bullet with those. So how we activate or how we action those lessons learned is going to be a big thing for us.
Great. I think that that's actually a perfect place to stop, to highlight obviously the importance of debriefing and getting our after action reviews and reports pulled together so that they truly do become lessons that we have learned from. Sounds like that's what you're all working towards as an organization. So perhaps we'll have you on as a speaker talking about your hurricane response in the future, but I'm wishing a quiet season for you on that front. I know that my colleague Francesco had just posted a quick comment in the chat as far as, continuing to follow us, and that the session is being recorded for folks I know that had asked questions earlier in the Q&A about, Mike, would your slides be available? But thankfully we've recorded the session, so they will be able to access those after the fact. But I think at this point I can say thank you, and I will turn it over to Francesco to close us off for the session. I get to say that you're muted, Francesco.
Oh, thank you. Thank you. It wasn't showing as muted on my thing. I think the headset was muted, but thank you. Yeah, no, thank you, Misha, for moderating the session and for all of your help with the series as always. And Mike, thank you so much for the presentation and for your answers to the audience questions. And of course, thank you to all of our participants who come to the sessions and participate and talk in the chat and ask their questions. It's always great when we have an interactive audience that finds these sessions interesting and useful. So with that, I would just quickly like to share my screen to show the next session that we have coming up. The fourth session, as you all know, this is a monthly series on the first Wednesday of every month. So the next session will be Wednesday, October 4th, same time, 12 p.m. And everyone will get the same reminders as always before the session starts. But registration, as always, is still open and it's free until the very last session. So if there's anybody out there who that might find these sessions interesting, that isn't registered yet, please keep sharing this and make sure it reaches anyone who might find the sessions useful or interesting. And with that, oh, right, I will also just mention that the speaker for the next session is Andrew Mole, who is a manager for the Disaster and Emergency Management in Hamilton Health Services, Hamilton Health Sciences, and is also a professor here at York University. So if they'll be talking about temporary patient housing during emergencies. So if that is a topic that is interesting to you, also just mark that down on your calendar and be sure to come check it out on October 4th. And so with that, I will stop sharing my screen and just give one last thanks to everybody for being here. And I can stop the recording.